He got the call on a Thursday afternoon. Your PSA came back at 8.6. He spent the next 4 days online, reading worst-case scenarios, barely sleeping, canceling plans, telling his wife he was fine when he clearly was not. By Monday, he had convinced himself he had advanced cancer, had mentally planned conversations he had not yet had researched treatments for a diagnosis he had not received. His appointment was the following Wednesday. His urologist walked in, reviewed the chart, then looked at him directly and said, "Before we discuss anything else, I need to tell you something. The panic you have clearly been experiencing for the past week is medically counterproductive, and it is based on a misunderstanding of what this number actually means at this stage." He asked, "What do you mean?" His urologist said, "PSA 8.6 is not a diagnosis. It is not a verdict. It is a signal that requires a structured response, not a panic response. And the men who do worst with elevated PSA are not the ones with the highest numbers. They are the ones who panic early and make reactive decisions instead of following a deliberate roadmap." He asked, "What roadmap?" His urologist said, "The one I am about to give you, 7 steps, in order. Each one answers a specific question before the next step begins. Follow this roadmap, and you will never need to make a decision based on incomplete information again." He pulled out a sheet of paper. That roadmap changed everything about how he navigated the next 18 months. Today, I am sharing that same roadmap. 7 steps, in order. Exactly what to do and when your PSA comes back high. Before we continue, quick reminder, this is educational information only, not medical advice. Every man's PSA situation is individual. Always work with your urologist to determine the right path for your specific numbers and health history. And if you want a free printable version of this complete 7-step roadmap, drop the word roadmap in the comments right now. Now, step 1, and why it has to come before everything else. Step 1, verify the number before you react to it. His urologist's first instruction was not what he expected. "Before we do anything else, I want to retest your PSA under controlled conditions." He asked, "Why?" The number already came back. His urologist said, "Because PSA is one of the most variable blood tests we use. Exercise within 72 hours before the draw. Sexual activity within 48 hours. A prostate exam performed before the blood draw instead of after. A mild urinary infection you may not have noticed. Any one of these can elevate PSA by 1 to 2 full points above your actual baseline. Do you know what you were doing in the 72 hours before your last test?" He thought back. He had cycled that morning. The night before was his anniversary. His urologist said, "You may have had 2 significant testing variables in the 24 hours before that draw. Let us find out what your actual baseline is before we plan anything around 8.6. He retested 2 weeks later. No exercise for 72 hours. No sexual activity for 48 hours. Blood drawn before physical exam. His retest, PSA, 7.1, 1.5 lower than the result that had sent him into 4 days of panic. His urologist said, 7.1 with your history is a very different starting point than 8.6. Step 1 just changed our entire conversation. The roadmap rule for step 1, never make any decision. Not monitoring frequency, not biopsy scheduling, not anything, based on a single PSA result taken under uncontrolled conditions. Always confirm under controlled conditions first. 1 retest, done correctly, before anything else. Step 2, understand your complete PSA picture. His urologist's second step was to pull up every PSA result he had on record and look at them together. Not one number. The complete picture. 5.8, 6.2, 6.7, 7.1, confirmed retest. His urologist said, "This tells me 3 things your single result could never tell me alone. First, your PSA velocity. You are rising approximately 0.4 points per year. That is below the 0.75 annual rise that research from Johns Hopkins identifies as clinically significant. Reassuring. Second, Your trend direction. Consistent slow rise over 4 years, no sudden acceleration. The jump to 8.6 was almost certainly a testing artifact, confirmed by your retest. Third, your baseline context. Starting from 5.84 years ago means your total rise is 1.3 over 4 years. Very different from a man whose PSA went from 5.8 to 7.1 in 1 year. PSA velocity, trend direction, baseline context. These three together tell the story that the single number never can. The roadmap rule for step 2. Before your next appointment, write down every PSA result you have ever received with the date it was taken. Bring that list. Ask your urologist to calculate your velocity and explain what your trend, not your number, tells them about your situation. Step 3. Calculate your PS, a density, and free PS, a ratio. His urologist's third step introduced two numbers his patient had never heard of: PSA density and free PSA ratio. PSA density. His prostate volume from a previous ultrasound was 65 grams. PSA 7.1 divided by 65 gives a density of 0.109, below the 0.15 threshold that research identifies as lower concern territory. Free PSA ratio. His free PSA on file was 19%, above the 10% threshold that raises significant concern, below 25%. So not maximally reassuring, but in the moderate range. His urologist said PSA density 0.109 and free PSA ratio 19% together tell me your prostate size is contributing meaningfully to this elevation. They do not rule out cancer, but they significantly lower the probability of aggressive disease compared to a man with PSA density above 0.15 and free PSA ratio below 10%. He asked, "Why didn't anyone explain these numbers to me before?" His urologist, "Because most appointments focus on the result, not the context around it. These two numbers require prostate volume measurement and a separate free PSA test, neither of which happens automatically unless someone orders them specifically." The roadmap rule for step 3. Ask your urologist directly, "Do we have my prostate volume on record? Has my free PSA been tested? Can we calculate my PSA density and free PSA ratio? And what do those numbers tell you about my actual cancer probability?" Step 4. Use a risk stratification tool before any biopsy discussion. His urologist's fourth step stopped him before the biopsy conversation even started. He said, "Before we discuss biopsy, I want to use one additional tool to quantify your cancer probability more precisely, not PSA alone. A validated risk calculator that combines multiple markers into a single probability estimate." He ordered a 4K score blood test. It combines 4 prostate-specific markers to calculate a personalized percentage probability of high-grade cancer, the kind that requires treatment rather than monitoring. His result, 11% probability of high-grade cancer. His urologist said 11% means 89% probability that if we biopsied you today, we would find either no cancer or low-grade disease unlikely to cause harm. That does not mean we ignore this. It means biopsy right now, before MRI, before any further evaluation, is not the optimal next step for your specific risk profile. Research published in European Urology, following over 6,000 men, found the 4K score reduced unnecessary biopsies by 34%, while missing fewer than 1% of high-grade cancers compared to PSA-based biopsy decisions alone. The roadmap rule for step 4. Before any biopsy is scheduled, ask your urologist, "Can we use a validated risk stratification tool like the 4K score or prostate health index to quantify my actual probability of high-grade cancer before we decide whether biopsy is the right next step?" Step 5. MRI before biopsy. If risk stratification warrants further investigation. His urologist's fifth step was conditional, triggered by step 4. He said, If your 4K score had come back above 20%, I would have ordered MPMRI immediately. At 11%, we monitor closely and recheck in 4 months. But I want you to understand what step 5 looks like so you know what happens if your numbers change. MPMRI, multiparametric MRI, creates detailed imaging of the prostate that identifies suspicious areas by their tissue characteristics. It does not diagnose cancer. It identifies where in the prostate further investigation is most warranted. The Precision trial published in the New England Journal of Medicine found MRI-targeted biopsy detected 38% more clinically significant cancers than standard random biopsy, while performing 28% fewer biopsies overall and finding 89% fewer insignificant low-grade results. His urologist said, "The reason MRI comes before biopsy, not after, is that MRI tells us where to look. Standard biopsy takes 12 samples from predetermined locations regardless of where disease actually is. MRI-guided biopsy targets the specific areas that imaging identifies as suspicious. Better information, better targeting, better outcome." The roadmap rule for step 5. If biopsy is being discussed, ask your urologist, should we do MPMRI first to identify any suspicious areas and guide the biopsy to the right locations, rather than using random systematic sampling? Steps 6 and 7, biopsy with purpose and a clear monitoring plan. His urologist outlined the final 2 steps together because they depend on each other. Step 6. If MRI identifies a suspicious lesion, proceed to targeted biopsy of that specific area combined with systematic cores. If MRI is clear, defer biopsy and intensify monitoring. Either way, biopsy happens with purpose and with information, not as an automatic response to a number. He said, biopsy is not inherently wrong. It is wrong when it is the first response to a number rather than a considered response to a complete picture. Biopsy after steps 1 through 5 gives us the best possible information about whether cancer is present, where it is, and how significant it is. Biopsy as step 1 gives us a result without context. Step 7, regardless of biopsy outcome, establish a defined monitoring plan with specific intervals, specific trigger points, and specific decision criteria. His urologist wrote it out: PSA retest in 4 months, free PSA at the same time. Repeat 4K score if PSA rises more than 0.5 points. MRI discussion if velocity accelerates above 0.75 points per year. Biopsy conversation triggered by specific defined criteria, not by anxiety. He said, "You now have a plan, not a number to worry about, a plan to follow." The roadmap rule for steps 6 and 7. Ask your urologist, can we establish a written monitoring plan with specific PSA thresholds, testing intervals, and defined trigger points so I know exactly what we are watching for and exactly what would change our approach? Imagine getting the call next time. Your PSA came back elevated. You do not panic. You open the roadmap. Step 1, schedule retest under controlled conditions before reacting to this number. You already know what to do. You already know what comes next, and the step after that, and all 7. That is what his urologist gave him on a sheet of paper in a Wednesday appointment after 4 days of unnecessary panic. He said afterward, "I spent 4 days terrified of a number that turned out to be 1.5 higher than my actual baseline. And even my actual baseline, once I understood the complete picture, was not what I feared." The roadmap did not change his PSA. It changed what his PSA meant to him. It will do the same for you. Share this with one man who got an elevated PSA result this week and has been online at midnight reading worst-case scenarios. And drop roadmap in the comments for the free printable 7-step guide, ready to use the next time that call comes.